Thank you, Dr. Shoaib. Good morning, everyone. I'm very delighted to have been given a chance to discuss this recent study that we carried out at the Pakistan Institute of Medical Sciences between June to December 2024, which was the diagnostic performance of 2D left atrial strain as a standalone criterion for diagnosis of heart failure with preserved ejection fraction. So as we know, heart failure with preserved ejection fraction is a complex and often underdiagnosed and undiagnosed condition, and the traditional echo parameters fall short and generally lack standardizations. So this prompts the need for a single, unified, and a simple criterion for diagnosis of such illnesses. As I said, it was carried out in the cardiac imaging department of Pakistan Institute of Medical Sciences between January to December 2024. The preserved EF subset of the heart failure roughly constitutes about 50% of the total burden of heart failure, and it is a challenging diagnosis due to heterogeneous presentation, heterogeneous diagnostic presentations, and the traditional markers have certain limitations. And it is a quite tedious process to diagnose and accurately label the etiology causing this subset of heart failure. So LA strain imaging, which generally measures the longitudinal deformation of the LA muscle using spectral tracking echocardiography, has been increasingly been emerging as a potential diagnostic as well as prognostic parameter for multiple diseases, but specifically for this heart failure with preserved EF. But it still hasn't been included in any standard diagnostic algorithms or criterion. The benefits that it offers is it is non-invasive, it is cost-effective, it is at least partially bedside, it is reproducible, it is standardized, it is less operator-dependent, and it can be followed over time. And also the most important fact is that it is neither load-dependent nor angle-dependent in this specific subset of patients. And the traditional LA parameters that look at the LA strain, that look at the LA function are either load-dependent or angle-dependent. This is how we generally look at the left atrial strain. It is measured in an apical 4-chamber, non-foreshortened and ECG gated image using semi-automated softwares. The softwares that we used were EchoPack GE version 203. This is a very robust and promising approach. 3 specific phases of LA strain can be identified. The first one is the reservoir strain, the second is the conduit strain, and the third is the booster pump strain. The reservoir strain is basically the maximum deformation that left atrium achieves before the mitral valve opens. The booster pump function is the end diastolic negative deformation that is achieved owing to atrial contraction after the onset of atrial contraction. And the conduit strain is the difference between these two values. So the objective was to determine the diagnostic accuracy of 2D left atrial strain with a cutoff of less than or equal to 23% as a standalone criteria for diagnosis of heart failure with preserved ejection fraction in all those patients who presented with exertional dyspnea and a preserved ejection fraction by standard parameters. It was a prospective single-arm, single-centric study at PIMS. The duration of study was 12 months. We enrolled a total of 150 patients with an intention to treat analysis who were more than or equal to 40 years of age with heart failure symptoms and a preserved LVEF using standardized echocardiographic parameters. The patients that were included were those having valvular heart disease that may independently affect the LA strain readings, presence of atrial fibrillation, and poor echo windows. And all patients had their echocardiography done, including LA strain reservoir measurements in both the 4-chamber and the 2-chamber views. And heart failure with preserved EF was diagnosed via HFpEF score with a score of 5 or 6 classified as diagnosed cases. The diagnostic accuracy results were that of a total of 150 patients, 92 were found to have, that is 61.3% were found to have heart failure with preserved EF using this diagnostic criteria. The mean reservoir LA strain in heart failure with preserved EF was 18.2. Our cutoff was less than or equal to 23. So the patients who were falling in the heart failure with preserved ejection fraction category, the mean reservoir strain was significantly low as compared to those who were in the non-heart failure preserved ejection fraction group. And this p-value was highly statistically significant. This is, I'm sorry, if it is not clearly visible, this is a 2x2 diagnostic table which shows the diagnostic performance of this criterion as a standalone test for this diagnosis. The sensitivity was 86.9%, the specificity was 80.4%, and the area under the curve was 0.89, which shows that this test showed remarkable performance. This graphically represents the mean LS strain rate in the heart failure with preserved EF group versus a non-preserved EF group. The mean in the preserved EF group was 18.2% and the mean in the non-preserved EF group was 28.5%. When we performed the ROC analysis and performance with a cutoff of less than 23%, I already mentioned these values for sensitivity and specificity. The positive value of the predictive value of a positive test was found to be 84.7%, and the predictive value for the negative test was found to be 82.8%. The area under the curve was 0.89 with a 95% confidence interval between 0.84 and 0.94. This serrated line basically represents any test that performs as good as random guessing, and the area under the curve for this serrated line is taken as 0.5. So any test which performs better than this, which forms on the left side of this curve, performs better than random guessing. And if the area under the curve is greater than 0.8, the diagnostic performance of a test is taken to be good, whereas if it is greater than 0.9, the test is taken to be of excellent or remarkable performance. So LS strain rate and the type of strain that we studied is the reservoir strain proved to be an almost remarkable test if taken alone for the diagnosis of heart failure with preserved EF when compared with the standardized gold standards. The conclusion is that it can not only serve as a standalone criteria, but it can also predate the possibility of developing heart failure with preserved EF, but by at least a decade. That is a lot of time that it can buy. This is a generally known fact that left atrial reservoir strains begins to fall even before volumetric analysis show any abnormalities in the echo. So even before the LS starts to dilate, the LS strain rate becomes abnormal. So it can not only accurately diagnose it, but it can also predict or predate the diagnosis by a significant number of years. Also, it has a prognostic value as well. That is, it can be followed over time, and some studies showed that any 1% improvement in reservoir strain translates into a 1.6% improvement in major adverse cerebrovascular accidents over the course of life for these patients. Thank you.